at Temple University. Oh, anyway, Dr. Paul Forfia is at Temple University Hospital. He's an advanced heart failure doctor and works with transplant patients. He's also part of the chronic thromboembolic hypertension. Is that what it is? Pulmonary hypertension program.
Right.
Is that correct? Yes.
Yeah.
Which is something that a lot of lupus patients get, where they have a different kind of pulmonary hypertension with a lot of blood clots, and it has to be handled quite a bit differently. Welcome, everyone. This is the Scleroderma Foundation of the Delaware Valley presenting this educational webinar, and I wanted to let you know that, as always with Scleroderma Foundation webinars, this is not to take the place of advice from a medical professional. This is for learning purposes and educational purposes only. And Dr. Forfia, would you like to take it from here? And you can take the screen if you want. Oh, you're muted now.
Yeah, no,
There you are.
my Zoom crashed again, but I'm back on. So first of all, welcome everybody. My name is Paul Forfia. I'm a heart failure transplant cardiologist by training, although I've been a pulmonary hypertension specialist the majority of my career. And I see all forms of pulmonary hypertension, of course, PAH, and thus lots of patients with scleroderma. I see patients with pulmonary hypertension with interstitial lung disease, and then also patients who have blood clots in their lungs. That's that condition called CTEPH that Katie was talking about. So I've literally been involved in pulmonary hypertension my whole attending career. This is really all I do professionally. And so Katie had given me some ideas for some topics to discuss, and between the wide array of the topics that were suggested and also my almost zero time availability to make a long and extensive talk, what I decided to do was to just be on the call with you guys and really field any questions or anything that comes up as it relates to scleroderma, pulmonary hypertension, interstitial lung disease, and try to function as a resource for the time we're on the call for things that you either have questions about or interested in. But let me start with just a brief kind of background, maybe sub 5 minutes, on refreshing everyone on what pulmonary hypertension is and what this term interstitial lung disease means. And then I'll stop there and we can kind of start taking some questions, okay? So pulmonary hypertension is, it's designated by the initials PH, right? Pulmonary hypertension. This is a very general term that can be elevated blood pressure in the lungs from any cause, okay? But if there are literally dozens and dozens of different types of pulmonary hypertension, and there's so many different types of pulmonary hypertension that many years ago we decided to categorize pulmonary hypertension into 5 major diagnostic groups, okay? And group 1 is the condition that we are going to focus mostly on in this discussion, which is, it's this condition called pulmonary arterial hypertension, PAH, right? Group 2 is pulmonary hypertension from forms of left-sided heart disease. Group 3 is pulmonary hypertension from forms of lung disease. And group 4 is that blood clot condition that Katie mentioned, that CTEPH, okay? Group 5 is a mix of what we call miscellaneous and multifactorial causes, meaning it can be from any number of different things that falls outside the scope of our discussion today. I'll try to put my camera on here, but I don't know how Well, yeah, see, it just freezes. Hello. So pH can be dozens of different things. PAH is very specific. This is pulmonary arterial hypertension. This is a disease of the blood vessels of the lungs. The lung tissue is normal, okay? So the bronchial tubes that carry oxygen, carbon dioxide in and out of the lung, they're healthy. The spongy tissue in the lung, healthy. But the blood vessels are thickened and narrowed, okay? And that's what causes this condition called PAH. For reasons that we do not understand, patients with scleroderma are at particularly high risk of developing PAH as compared to the general population, okay? So to give you an idea, it's estimated that PAH occurs in somewhere around 15 to 25 people per 1 million people, okay? So it's pretty rare. But PAH can occur in a scleroderma patient in their lifetime with a risk of about 15%, okay? So if the average person in the general population is 10 out of 1 million people, in scleroderma, it's 15 out of 100 people, okay? So the risk is much higher than the general population. It doesn't mean that if you have scleroderma, you're automatically going to develop PAH, but it does mean that we have to look for it and watch for it. And of course, if you have it, then of course we have to diagnose it and treat it as aggressively and effectively as we can, okay? And so this is the very special form of pulmonary hypertension, PAH, that nearly all of the medicines that are approved in the United States for use to treat pulmonary hypertension, they're designed specifically to treat PAH, okay? Interestingly, it's only recently that a medicine has been approved to treat pulmonary hypertension in patients with what we call interstitial lung disease, okay? And interstitial lung disease is a form of lung disease that is not COPD, that is not emphysema, okay? It is a form of essentially scarring in the lung that can occur from a multitude of causes, although one significant risk factor for ILD is also scleroderma, okay? Now, what's important to understand is that we categorize pulmonary hypertension like, oh, the group 1, the group 2, the group 3, right? But sometimes people will have pulmonary hypertension that kind of overlaps 2 different groups. So let's say a patient has scleroderma and they have all the features of PAH, but they also have interstitial lung disease. That person's pulmonary hypertension is something in between group 1 and group 3, okay? Now, we have been treating those types of patients that don't specifically fall into the group 1 category for a long time, okay? But it's only been like officially said that it's okay to treat patients like that for like the last year and a half. But that's just because a lot of times the studies lag behind the clinical practice, okay? And so let me just stop there for a second and see if any questions come up from anyone related to what I've talked about thus far. Remember that you have to go off mute if you want to speak. And so if there's no questions, or if people, oh, I see somebody putting their hand up, Barbara. You just have to take your computer off mute, honey. On the bottom left of your computer, there's a little, there you go, you got it.
I have ILD, and in May, I haven't had any heart problems. In May, I suddenly went into third stage heart failure. And I guess the sinus node was not working at all. So the ventricles were not getting the signal from my heart to beat. And I wound up with a pacemaker.
Right.
Now, I had spoken to the cardiologist, and they didn't think that I have dermatomyositis. They didn't think that that had any relationship to it. But I feel it did. This might be a little bit off topic, but I just feel that it had something to do with damaging, that node, which does not work anymore.
Right. So it's certainly possible. And there are issues that can occur with what we call the conduction system of the heart.
Right.
Imagine that the heart actually has a mechanical pumping ability, which of course it does, but it also has specialized cells that essentially function as electrical wiring within the heart. The heartbeat originates at the top right of the heart, and it's called the sinoatrial node, SA node.
Mhm.
And it initiates the electrical impulse that stimulates the heart. That travels across the top chambers of the heart and then through a little filter, an electrical filter called the AV node, and then down to the bottom chambers called the ventricles, which then excites the muscles in the ventricles and stimulates them to contract, okay? What it sounds like happened there is that you had some form of scarring that developed in that filter down there called the AV node.
Mhm.
And then what happens is, instead of the top chamber of your heart initiating the heartbeat, which is like 70, 80 beats per minute, the bottom chamber will initiate the heartbeat, but it'll be at like 40. Okay. And that's generally too slow for most people to feel well. And they can even develop congestive heart failure when their heart is beating that slowly. And so it definitely is something that can happen just with age and with other chronic medical problems. But we definitely see with conditions like scleroderma that thickening and scarring that you can see in the skin can actually occur other places, including in the heart. And so it is possible that your theory is correct, that your underlying condition played some role in making it more likely that you ended up with a pacemaker. The good news is that that is not the type of thing that is going to make a major impact, negative impact on you. The pacemakers work very well. The technology is amazing. And it's really something that will allow you to kind of bypass that problem and just move on with your life. So, I'm glad that you got a pacemaker put in, and I'm assuming you're feeling better since the pacemaker was put in.
Yes, I still have Pvcs, but I'm definitely, I was down to 30 beats a minute.
Yeah.
So I'm definitely much better.
Yeah. Well, that's good. Yeah, it sounds like you had something called complete heart block.
I did.
Yeah, and then that would be easily fixed with a pacemaker. So that's great. And then I see someone putting up their hand there in the center of the screen. Okay, honey, you got to go off mute though if you want to talk. Go ahead. This is
okay.
fun.
I hit unmute. Did I do the right thing?
You did it.
I have a Watchman, and it's leaking. Should I be concerned?
Not necessarily. Do you know if you're in atrial fibrillation?
Yes, I am.
Okay. Are you on a blood thinner?
No, that's why they gave me the Watchman, so I
Okay.
could stop the blood thinners.
Okay. How did they know that the Watchman was leaking, honey?
On a CAT scan that I had taken about 3 weeks ago.
Okay. Does the doctor who put in the Watchman, are they aware of the fact that it's leaking?
I called and told them. I have an
Well-
appointment in December with them,
Uh-huh.
but he didn't want to see me before that. So I'm assuming it's okay.
Well, are you on an aspirin, honey?
Yes, 80
Okay.
milligram.
Good. So that's important to maintain the aspirin. And then, it's just a matter of sometimes there'll be a little bit of a gap there in that little device. And other
Okay.
times it's something bigger. And so they'll have to determine whether that little leak that you're referring to is something that is significant or whether it's something that's not significant.
Okay. Thank you very much.
But you are partially protected from being on the aspirin, so that's positive.
Okay.
All right. I think Stephen, go ahead.
Hi. How does arterial calcification figure into PAH, if at all? High calc rate make a difference?
A high what?
Calcification rate.
So patients with PAH can develop calcium deposits in the walls of their pulmonary arteries. It typically does not factor in a major way into the progression of their disease, okay? Typically when we see calcium in the walls of the pulmonary artery, it's more indicative of the length of time that someone has had pulmonary hypertension, but not necessarily the severity of the pulmonary hypertension, okay?
Yeah.
And so, I can't say that it plays a major role, okay? It can serve to stiffen the larger arteries in the lungs, but that generally does not affect the right side of the heart to a major degree. And that's the most important determinant of the severity of any individual patient's PAH is how well the right side of the heart is doing or how poorly it's doing. And so let me just touch on that just for a second. Sometimes people get a little confused when they say, well, why is a cardiologist, a heart doctor, taking care of patients with pulmonary hypertension, right? And the reason is that pulmonary arterial hypertension is really a cardiovascular disease. Cardio means heart, vascular means blood vessels, and the blood vessels of the lungs are diseased, and it very much affects the way the heart works, okay? The way the heart pumps, it can affect the rhythm of the heart. Like one of our, I think who was talking about their pacemaker just a minute ago, right? Barbara, yeah, so it can affect the pumping function of the heart, the electrical function of the heart. And so it's very important for any patient with PAH that when they're treated with medication, that we treat them to the point that the right side of the heart goes back to normal in size and function or as close to it as possible, okay? Because what determines how sick someone is with PAH is principally determined by the status of the right side of their heart. If their right side of the heart is normal in size and their right side of the heart is normal in function, that person will have a very good prognosis from their PAH. Conversely, a person who's treated with PAH, whose right heart remains enlarged and does not function well, is not going to do as well long-term unless the medicines are changed to get that right heart smaller and the function better. Does that make sense to everybody? Okay.
Yes.
And so what can seem like a paradox of why a cardiologist would treat PAH, when you look at it actually from the perspective of being a physician, actually it makes perfect sense. Because the thing that we're watching most closely in patients with scleroderma PAH is their heart. It's specifically the right side of their heart. Yes, Stephen.
So do I understand correctly that you're not an interventional cardiologist? That the treatment is medicinal, or you're not going into the chest to alleviate the situation, or not?
Correct. So I do heart catheterizations, but I do not do what are called interventions, which are like angioplasty, stents, percutaneous heart valves, things like that. And so there is no catheter-based or surgical-based technique that will fix PAH.
Okay.
It is a condition that requires medical therapy. Okay. Now, the other aspect of what I do, which is called that CTEPH thing,
Mhm.
chronic thromboembolic pulmonary hypertension, that has 3 forms of treatment. Medicine and surgery is actually the major treatment, where we actually go in, we put a person on the heart-lung bypass machine under anesthesia. We actually open up the pulmonary arteries and we physically remove the chronic blood clots from their lung. We just take them out, okay? And that can actually cure a person who has very severe pulmonary hypertension. It can completely cure their disease. And then a new technique we've been using over the last 5 years is what we call balloon pulmonary angioplasty, where we actually, where there's narrowings in the blood vessels of the lungs from old blood clots, we stretch open those narrowings with a balloon. So Stephen, no, we don't use interventional techniques for PAH, but we do use it for another form of pulmonary hypertension.
Thank you.
Dr. Forfia?
Mhm.
In the chat box, Connie said, where is the decision-making in lowering the requirements from a pressure of 30 to catch PAH earlier? And she's been reading some studies about that and
Yeah,
had some questions.
sure. Yeah, it's a good question. So, guys, every 5 years, we have these meetings called the World Symposium meetings. And it's a bunch of fancy experts in pulmonary hypertension from all over the world. This scrappy looking guy being one of them, okay? And we basically review all the information on pulmonary hypertension and PAH, and we update the medical literature and the guidelines on how to best diagnose and treat these conditions, okay? And in the history of these meetings, which started in 1972, the most recent one was in 2018, okay? It was in Nice, France. And in that meeting, as this participant is suggesting, the cut point for defining pulmonary hypertension got dropped, it got lowered, okay? Now, so what did it get dropped from? When we measure the blood pressure in the lungs, we do it in the 3 ways, okay? It's the same ways that you measure blood pressure. You measure a top number, a bottom number, and an average number, okay? So for example, if you're taking blood pressure like in someone's arm, right? Their blood pressure may be 120 over 80, okay? Top and bottom number. And then what's called the mean or average pressure would be around 100 millimeters of mercury, okay? You guys with me there? When we measure pulmonary pressure, we also measure a top number, a bottom number, and an average number. The long-standing definition of pH, elevated blood pressure in the lungs, pulmonary hypertension, was an average or mean pulmonary pressure of 25 millimeters of mercury or more, okay? In the 6th World Symposium in 2018, the cutoff was dropped from a mean pulmonary pressure of 25 to 20. okay? The idea behind that was to see if we could diagnose more patients with pulmonary hypertension, okay? That, in theory, could work, although in reality, probably won't. And the reason why is because most patients, when they present with pulmonary hypertension, present with numbers far higher than 25. The average person, when they come to the doctor's office with shortness of breath, their mean pulmonary pressure is in the 40s. It's much higher than the average cutoff. And so, dropping the mean pulmonary pressure cutoff from 25 to 20 was theoretically a good idea, but in clinical, actual real life practice, it is probably going to make very little difference at all. But you're right, that was the intention of dropping the cutoff down from 25 to 20. It's just that I don't think that it was actually correct. And the reason is they dropped the cutoff so low that you're essentially casting too wide of a net. And so my fishing analogy is, if you had a net that was 500 meters in diameter out in the open ocean, looking to catch tuna, you may catch, however number of tuna. But if you now use a net that's 5 times larger than that, what you're going to pull into your boat is going to be tuna and a whole lot of other stuff. Okay? And that's what's happening with the lower cutoff, is people are coming in with pressures that are much lower, but it's not clear at all whether that's actually a disease. The numbers are so low that many of these patients have no symptoms. The right side of their heart is normal. They feel great. And then you ask yourself, what did we actually identify here? Does that make sense? So imagine that if a person feels great, looks great, right side of the heart looks normal, but now they've met the definition of pulmonary hypertension. Are you supposed to treat them? Right? And the answer, of course, is no. Because if you put patients on potent medications to treat pulmonary hypertension, and they're actually perfectly healthy, they'll generally just get medication side effects from the drugs. Okay?
Dr. Forfia, Anita wrote, does a PAH increase risk of arrhythmias such as PACs or Pvcs? And then she also wrote, what percentage of patients progress from proven PAH on exertion to PAH at rest?
Okay, just give me 1 second to just answer a text. Okay, that's done. So I'm sorry, what was the first question?
Does PAH increase risk of arrhythmias such as PACs or Pvcs?
Okay, the answer is yes. So remember I mentioned before that you could consider the heart as having like a mechanical pumping function and also an electrical wiring system, right? Well, if the mechanical pumping function of the heart is not normal, okay, it is off because a patient has PAH, the right side of their heart is enlarged, okay? That can affect the electrical system of the heart, especially the top chambers, what are called the atria, okay? And there's a couple of rhythms that we can see in patients with PAH. The most common is one called atrial flutter. And then another one is called atrial fibrillation. Atrial fibrillation is a very common arrhythmia in the general population, but atrial flutter is a more common arrhythmia in patients with PAH. And the reason is because atrial flutter originates from the top chamber of the right side of the heart. It comes from the right atrium. which is more likely to be abnormal in patients with PAH. So the short answer to your question is yes, PAH patients are at increased risk of arrhythmia, but particularly arrhythmias of the top chamber of the heart or the atria, okay? An important thing for you guys to know is that patients who have atrial arrhythmias in the setting of PAH, oftentimes when they go into the atrial arrhythmia, they will not feel as well. They'll start to feel more tired. They may start to feel more short of breath. And they may even start to show signs of fluid retention, like swelling in their ankles, okay? And actually start to develop signs of congestive heart failure. And so if you feel irregular heartbeats, what we call like palpitations, it's important that you let your doctor know that that's going on. Because if your heart is out of rhythm, we like to know that so that we can correct it. And there's lots of ways to correct it, okay? So you don't want to be sitting home for 3 months with palpitations and not telling anybody. Because you can actually get significantly sicker just leaving yourself in an abnormal rhythm, okay? And then the next question.
What percentage of patients progress from proven PAH on exertion to PAH at rest?
Right, it's a great question. There is not a ton of like large scale studies on this yet, but the short answer is that exercise pulmonary hypertension oftentimes does not progress to the development of full-blown resting PAH, okay? This is a little bit of a controversial area, you know, because what some have argued is, okay, if you have a patient with scleroderma and they don't have pulmonary hypertension, you should do an exercise study to see if they have any exercise pH. And if they do, you should probably treat it. But that's actually not true. Because if a person has mild, very mild pulmonary hypertension, like it doesn't even meet the definition at rest, in almost all cases, that person, the right side of their heart is going to look normal, okay? And if you exercise them, their heart function through a range of exercise will respond relatively well. And so if we try to treat exercise pH before it becomes resting pH, what you'll often find is patients get a lot of medication side effects like low blood pressure. They feel lightheaded all the time, headaches, flushing. And so what happens is they get all the side effects from the medication, but they don't get the positive effects from the medication. And so there are a couple of studies that have looked at patients with exercise pH, and then they followed them out for like 3 years. And in the majority of cases, the patients who had exercise pH 3 years later, they did not have resting pH. Okay?
So sometimes you leave it alone?
Yes, you do. You leave it alone and you just make sure that they follow up with you in clinic, right? We don't leave it alone and say, I'll see you back in 3 years. You follow them every 4 to 6 months and make sure that everything is, you know, is okay. My experience with this condition, and I have one of the largest exercise labs in the United States. So we've done a lot of exercise studies. Patients who have this very, very, very mild form of exercise only pH, in the majority of cases, you follow them over time and they don't actually get sick from that. Okay.
Dr. Forfia, Stephen has a question in the chat box.
Oh.
Please explain the anatomy of the right and left side of the heart. This is evidently a right side situation.
Yes. So, well, you're asking the right guy, because this is literally what I've spent most of my entire career researching. And so when I was a young cardiologist in training, I realized that there were very few doctors out there actually studying the right side of the heart. And I was like, maybe I'll be a right side of the heart expert. Well, turned out that that's what happened. I've been studying the right side of the heart since about 2003, and I haven't stopped yet. And so the right side of the heart and the left side of the heart are very different, okay? And so I'll start by just explaining the general purpose of the right side of the heart and the general purpose of the left side of the heart, okay? The right side of the heart receives blood from the body through the veins. So imagine that all the blood that's coming like from your fingertips back to your heart, or from the tips of your toes back to your heart, okay? That is venous blood, okay? The oxygen has been taken out of it by the body. It's a darker color. It's like a maroon color. And it is traveling up or through the veins of the body, and it comes in through the top chamber of the right side of the heart called the right atrium, okay? It then goes down into the right ventricle, and the right ventricle's job is to squeeze and eject that blood through the blood vessels of the lungs, the purpose of it being to get rid of the toxins in the body, namely carbon dioxide, and to get oxygen into the bloodstream, okay? So the right side of the heart receives the venous drainage from the body, drops it down into the right ventricle, which pumps it through the lungs. The CO2 goes out your mouth. You breathe out the CO2. You breathe in the oxygen, and that washes into your bloodstream in the lungs, okay? That blood that's now rich in oxygen, and it is bright red, okay? The difference in color between venous blood and arterial blood is very striking. It's a maroon color in the veins, and you guys have all seen yourselves get blood drawn. You see how dark that blood is, right? That's venous blood, which is relatively poor in oxygen. The stuff that goes into the left side of the heart and ejects out to the body is like almost like a neon color red, okay? And that color difference is related to the fact that it's loaded with oxygen, okay? The left side of the heart receives that oxygenated blood through the lungs, and then the main pumping chamber is called the left ventricle, which then ejects that blood under high pressure up to the brain, down your arms, through to all of the internal organs in your chest and abdomen, and down into your legs, etc. Okay? And so the right side of the heart pumps blood through the lungs that allows gas exchange, and the left side of the heart pumps oxygen-rich blood to the tissues of your body. It makes your muscles move, makes your brain work, makes your heart work, makes your kidneys work, okay? Now, because of these different functions of the right and the left side of the heart, the structure of the right and the left side are very different. The right side of the heart pumps blood under low pressure, under normal circumstances. And so the actual weight of the right ventricle, what we call the mass, like if you cut the right ventricle and put it on a scale, it weighs about 1/6 that of the left ventricle, okay? The walls of the right ventricle are quite thin and floppy. The walls of the left ventricle are thick and strong, okay? So imagine that the right ventricle is designed to be kind of a thin, floppy pump that just very kind of gently and gracefully just pumps blood through the lungs for gas exchange. And the left ventricle is like the whopper that really slams that oxygenated blood out of the left side of the heart so it circulates throughout the whole body. And so the right side of the heart is smaller, has a thinner wall, is much lighter, the mass is less. And that again relates to the completely different functions of the two sides of the heart. And Stephen, do you think, has that answered your question sufficiently?
It has. Thank you very much. That was very useful.
Sure.
And Dr. Forfia, Nancy asks, how often should a person with limited systemic sclerosis have an echocardiogram to measure pulmonary pressure? She was diagnosed with limited scleroderma in 2019, and she's had one echocardiogram. Results said that the pulmonary pressure could not be determined.
Right. Okay. So this is a really great question. So the recommendations from both the American College of Rheumatology, what we call the ACR, and also from our organization, which is the American College of Cardiology, is that patients with scleroderma get an echo every 6 months. Okay. And so if you have not had an echo since 2019, you're definitely overdue for one. Okay. It is not uncommon for there not to be a certain Doppler feature on the echo, therefore they cannot estimate the pressure. Okay, so that's not terribly uncommon. May I ask, for the person who asked that question, has there been any changes in your symptoms? In other words, like, are you short of breath now, whereas you weren't before, or are you still feeling okay?
No, I'm still feeling okay.
Good.
I'm still feeling okay, and so
That's
it's fair. Yeah.
That's a positive. And so usually when patients develop PAH, whether it's in scleroderma or otherwise, it really affects their exercise capacity. Because when the right side of the heart becomes affected by the high pressure in the lungs, you cannot pump enough blood through your body to keep up with you, right? So imagine if you wanted to walk 2 blocks and your heart function was supposed to double in order to keep up with the 2-block walk. If you have PAH that's untreated, you won't be able to do that. You'll get a half a block and be like, wow, I can't do this, right? And so the fact that you don't feel any different is a positive. And just as a sidebar comment, usually, not always, but usually, when the echo cannot estimate the pressure, it's usually because the tricuspid valve is not leaking, because the right side of the heart is completely normal. Okay?
Okay. All right.
In which case, that's a positive. Okay?
Thank you very much. Thank you.
You're welcome.
Now, I have another question. This is Katie. Toby's saying, how do exercise and medication for PAH work together?
Yeah, so another good question. So there's no evidence that exercise itself affects the pressures in the lungs or the way that the right side of the heart works or lowers like the resistance in the lung or anything like that. Okay. The purpose of the medication is to relax the blood vessels of the lungs to what we call unload the right side of the heart that allows it to pump more efficiently. Okay. Imagine that if the right side of your heart, imagine if the right side of your heart was like your arm, like a bicep, like you were doing, like lifting weights, like a weightlifter, okay? If normally the right side of the heart is only lifting a 5-pound weight to function normally, in PAH, it's actually being asked to lift like a 50 or an 80-pound weight. And it's under that condition that the heart really becomes strained and starts to fail. What the medications do is they open up the blood vessels of the lungs, relax the muscles in the walls of the blood vessels. The blood vessels actually become larger, okay? And then that effectively takes a weight off the heart. So if you're normally supposed to be a 5-pound weight in the right ventricle and it's 50, you put people on medicine and it's like bringing the weight back down to 12 pounds. You with me? Now, in exercise, there is no evidence that exercise actually changes the way that the blood vessels of the lungs function or the way that the right side of the heart functions. However, there is evidence that exercise will condition the rest of your body, which can make you into an overall more fit and strong person, which allows you to compensate better in the setting of PAH, okay? So it's like, it doesn't treat the PAH itself, but it treats the body that surrounds the PAH. And that has been shown to be beneficial. The last thing that you would ever want to do if you had a heart and lung condition like PAH is to be a sedentary person who becomes physically weaker over time. Because then you're actually compounding your problem. Because not only do you have the PAH process, but your body is progressively weakening over time. And that's not to your benefit. So we definitely recommend that patients with PAH get regular exercise. Sometimes that is misconstrued to thinking that people should be running the Rocky Stairs at the Art Museum every morning. What we're talking about is it can be a modest level of exercise. It can be just going for a walk, 10, 15, 20 minutes a day. But you should be doing some form of activity most days of the week so that you maintain a degree of health and tone in the muscles of your body. This is not even mentioning there are a multitude of other beneficial effects of exercise, which include that people who exercise sleep better, people who exercise are less likely to carry excess weight, and people who exercise regularly are less likely to be depressed or anxious. So there is all kinds of other benefits of exercise besides just the things that you commonly think about.
Is it important to not, with PAH, is it important when you're exercising to not get your heart rate up too high?
So, yeah, if you have established PAH, particularly if your PAH is, is significant, it's, the right side of your heart is not back to normal, things like that, then a kind of mild or modest level of exercise is safe and is still beneficial, okay? Most patients with PAH would struggle to try and reach what we call maximal levels of exercise, okay? Because even when a patient with PAH is very well treated, it would be difficult for them to actually exercise to a full maximal capacity, and their heart would be able to keep up with that. And so, a reasonable way to think about it from a heart rate perspective is to look at what your baseline heart rate is, okay? And then exercising to, say, 30% above that, but no more, okay? Does that
Okay.
make sense?
Yes. My PAH is at 26. I was diagnosed with PAH with
I'm not sure what you mean by 26.
the cutoff you said is now down to 20. It was
Right.
25. I'm
Mhm.
at 26.
Okay. And are you on medication?
I am.
Are you on one medication?
I'm on one medication.
Yeah.
They tried to put me on two, and I couldn't tolerate it.
Aha. Hey, guys, remember what I told you before? When patients have mild PAH, like you're describing, right? Toby is saying she is very mild. This is very mild disease. Mean pulmonary pressure 26 is very mild. I would have predicted that if they tried to put you on two medicines, you would have felt worse. So if you're going to treat mild PAH, you have to use a mild amount of therapy. The way I teach it is that the treatment, the intensity of the treatment should match the intensity of the disease. Okay? Does that make sense? So it totally makes sense that with a mean pulmonary pressure that's very minimally elevated, like 26, that when they tried to hit you with the two big gun hammers there, that you felt worse. And then they had to stop the one and put you on the milder form, the other one. And I would be willing to bet that on the one medicine, you don't even feel any different than you did before.
I think you're right.
Yeah. And it's because when your pressures are that low, it does not impair your cardiovascular system to a significant degree. Okay. And so if they put you on the medicine, it's not likely you would feel any different because you weren't sick to begin with. And by the way, that's a good problem to have.
Right. But so if I still get out of breath walking around the block and I use a portable oxygen, would you guess that that's not from the PAH, that's like from the interstitial lung disease, or?
I would, yes. So I'm going to assume for a second that when your oxygen levels were low, they were measured accurately, and that it was not your Raynaud's that's threw off the meter. Okay.
They were measured across my forehead.
Good. And so that's more likely to be correct. And so if you have a mean pulmonary pressure of only 26 and you require oxygen when either at rest and or with walking, it's more likely than not that the scleroderma has affected the actual tissue of your lungs, which is that condition called interstitial lung disease that we talked about.
Okay.
Yep.
Okay. Thank you. That's helpful.
Sure.
And there's a few more questions in the chat room.
Okay. I'll put my glasses on and look here. So let's see. I'm getting old, guys. I got the reading glasses. I need them. I hate to admit it, but I do.
Welcome to the club.
All right. So I was diagnosed with scleroderma in 2020. Normal baseline echo. A year later, they found mild pH on my next echo, not symptomatic. Had a right heart cath, which showed pressure of 24.5. I have normal pulmonary exercise test, still not symptomatic. I understand, and pH has no cure. Is this just to be monitored? Okay, so we had a lot of questions about these like borderline cases. And so all you guys are doing is you're just proving me right as this goes on. Remember I said, when people have this very, very mild form, just it's not clear whether that's really a disease, okay? Guys, let me explain to you when PAH is definitively a disease. You ready? The mean pulmonary pressure is elevated. Pick a number. the pulmonary vascular resistance is elevated, okay? And most importantly, the right side of the heart is starting to become enlarged and dysfunctional. When the right side of the heart is becoming affected by the pressure in your lungs, that is when you know for sure that the person has the real thing, okay? By the way, when you treat that person, they will feel better on the medicine, okay? Like almost every time. And so what this person is describing, this just needs to be followed, okay? And the fact that you said you had a normal echo, typically when people say they have a normal echo, that typically means that the right side of the heart is also normal, right? And so I would absolutely think that with a mean pulmonary pressure of only 24, that your right side of your heart is normal. And all you need to do is just pay attention to your symptoms or lack thereof. And basically, I would just say, try and relax because it's okay. You're okay. Get your echoes every 6 months. And if you feel any progression where you're saying, you know, I'm actually starting to get winded, just let your doctor know, okay? But I don't want you to think that that 24.5 is going to go to 34.5 to 44.5 to 54.5 over the next 3 years, because the science says that that typically does not occur. The way I explain it to patients is also, if you were to have full-blown PAH, honey, you would have had it by now. Okay.
Dr. Forfia, there are 3 last questions in the chat, if you have time for them. The first one is, what are the side effects of the potent medications?
Okay, so I will, I'll kind of back up a little bit and say that we have, it depends on what you define as a potent medication, okay? All of the medications for PAH have side effects, okay? Some of them are more difficult to tolerate than others though. So I'm gonna start with the medicines called Pde5 inhibitors. Those are the ones that are like sildenafil and tadalafil, like Revatio and Adcirca, okay? Very commonly prescribed. The most common side effects of those are a little bit of like a feeling of being flush. Sometimes people can get like a headache, and some people, they can get like a feeling of like a little bit of like an upset stomach or like heartburn, okay? Okay, the next set of medications are what are called the ERAs, endothelin receptor antagonists. They are like Tracleer, Opsumit, Letairis, okay? The other trade names for them are like Macitentan, Bosentan, and Ambrisentan, okay? These medications, the principal side effect of those medications is fluid retention. People will start to get swelling in their ankles, which can be a bit of a nuisance. And at times it's more than a nuisance, it's actually a big problem, okay? Sometimes we have to stop that medication because people get so puffy on it that it's not actually a good medication for them, okay? And then I think that the class of medicines that the participant was kind of alluding to when they said potent medications are a whole class of medications called prostacyclins. Okay. Prostacyclins are classically the ones that are put in through the pump, like into the IV or under the skin. But nowadays, we even have inhaled prostacyclins, and we have prostacyclins you can take by mouth, okay? Generally speaking, the prostacyclins have the largest array of side effects. Some of the more generic side effects are flushing, like your skin feels flush, headache, jaw pain, like people actually say that when they take a bite of food or a drink, see if my camera works. because I can demonstrate it to you if my camera damn works. All right, I'll try to get the camera back bone, but people will actually feel like this weird like pain or twinge sensation in their jaw. Sometimes people can have like aching pain of their lower legs. And then there are other gastrointestinal side effects like loose stools, diarrhea, nausea, okay? And in some people, the side effects of the prostacyclins can really be a big problem, where they really feel lousy on it. You know, they have a headache, they're flushed, they're nauseous, they have loose stools, their legs hurt. And so usually, if your medicine is being adjusted by someone who is skilled at using them, we adjust the dose slowly over time so that you can tolerate the medicine relatively well. The prostacyclins are not designed to just be like blindly cranked up aggressively. If that happens, people usually feel pretty miserable, okay? So there is a bit of an art and a skill to the adjusting of the prostacyclin medication so that you get the effect without being overwhelmed by the side effects, okay? And then I think there was an additional question in there.
Yeah, there were two last. One says Tyvaso therapy for group 3, PH-ILD scleroderma. Any comments on how effective it is as monotherapy? Are patients having significant side effects?
Right. So you're right that Tyvaso was approved recently for PH in interstitial lung disease. But as is always the case, the actual story behind that is a little bit more complicated than that. I hate to break it to you. And so the patients who actually benefited from Tyvaso in that study had actually pretty significant pulmonary hypertension. It was only the people who had what's called a pulmonary vascular resistance more than 5 with right heart dysfunction that actually improved. So for example, let's say that our patient on the call who said their pressure was 24.5 with a normal echo, if that person had interstitial lung disease and they went on Tyvaso, they would feel like crap. They probably would cough all the time, get a headache, maybe feel dizzy when they stand up, and they would not breathe better, okay? And the reason is because their pulmonary hypertension is so insignificant that there's nothing really there to treat. In the PH-ILD study, it was only the patients who had a solid, moderate, or greater degree of pulmonary hypertension that actually benefited from the Tyvaso, okay? Common side effects are cough, although most of the time it's well tolerated. And the medicine is inhaled anywhere between 3 and 12 times a day, 3 to 12 breaths 4 times a day. There was some other comment or question embedded in that. What was it besides the PH-ILD?
How effective it is as monotherapy?
Yeah, so it was in the patients who had like PVR greater than 5 with right heart dysfunction, it was quite effective. It lowered the pressures, lowered the resistance, improved their right heart function, their exercise capacity improved. And so, yeah, it was quite effective. But that does not mean that Tyvaso is going to be the answer for every patient with PH-ILD. And what I would definitely recommend, guys, is if you have ILD and pulmonary hypertension, I would really recommend, and I don't always say this, but I would really recommend you follow with someone at a major university medical center. Because if you think treating PAH is tricky, group 1, PAH, treating PH and ILD is 3 times as tricky. So you really want to have somebody helping you out who is really an expert in doing this. I would hate to see people just kind of getting Tyvaso thrown at them without a lot of thought, okay? And so we do recommend patients with PAH be followed in a specialty center, a center of excellence. And I would double or triple down on that and say that patients with PH-ILD, you really should be seen at a major center. It's tricky business.
Thank you. And then the last question was from Nancy Paul, who says, I have a pacemaker due to sudden complete heart block from 2018.
Yep.
I also have tricuspid and mitral valve insufficiency. Is that related? Had the valve prolapses first, and she has diffuse systemic scleroderma since 2008 crest.
Okay. So the leaky valves are not necessarily related to the complete heart block, okay? The complete heart block is typically an associate of any condition that increases the accumulation of any type of scar or calcium deposits in the electrical wiring of the heart, okay? And that can include scleroderma, by the way, all right? And so, and of course, there is an age associate to that as well. Generally speaking, people with complete heart block who get a pacemaker do fantastic, okay? So I would consider that almost like a thing of the past. The only thing is you gotta watch is the battery life on your pacemaker, which I know they're doing, right?
Yeah.
And as far as the leaky valves, that's where you need to be followed by an expert cardiologist to determine whether the valves are, the leakiness is significant or is insignificant. And we can tell that from an interview, a physical exam, and an echocardiogram. Because there's a big difference between a mildly leaky valve and a severely leaky valve.
A mile.
Yeah, and so mild leaky valves typically stay mild leaky valves. So more likely than not, your leaky valves will just be something that they keep talking to you about, but are never going to pose a problem for you.
Okay, I have interstitial lung disease too, but it's mild. That's also mild.
Right, and so that's also good. And so interstitial lung disease in many patients tends to progress very slowly, or in some people it doesn't progress at all, okay? Guys, one thing I want to mention before we wrap up is any patient who has scleroderma who has any problem with their swallowing function, their esophagus, okay? That can pose a risk for developing scarring of your lungs over time through a condition called aspiration, where whether you realize it or not, saliva and liquid from your mouth can make its way down into the lungs and set off an inflammatory reaction and over time scar the lungs down, okay? And so remember I said that any patient who has PAH, if they felt palpitations, they definitely should let their doctor know, right? Any patient with PAH who is feeling more short of breath, they should let their doctor know. Okay, here's my third one. Any patient with scleroderma who is starting to notice that they're coughing after they drink or coughing after they eat should let their doctor know, because that can be an early sign that they're actually not all of their food or drink is making it down the swallowing tube, and some of it is making its way into the trachea, into the airway, which can mean that you're actually aspirating. And so definitely, if you have scleroderma and you notice that when you take a drink of water, you every time you drink, definitely let your doctor know that, because it can be an early sign of the fact that your swallowing function needs to be looked at. Okay. You don't want to let something like that go, and then it really scars your lungs and damages them over time. Okay.
Wait, I have one more question. The PAH you were talking about, mine's on my echoes, it started at 26 and every year it went up to like 34 and then it dropped back down again. I guess it's okay because it's that it drops down. I don't know why it would just drop down.
Say that one more time.
My on an echo, my pulmonary hypertension, my number was 26. Then every year it went up and up and up until 34, and then it dropped back down to 28, I think.
Right. Okay. So
Nothing to worry about.
no, it's not, and I'll tell you why. So remember I said that the pressure number that defines the cutoff for pH is that average pressure, the mean pressure.
Yeah.
It's not the top or the bottom number, it's the middle number. Okay. What the echo measures is the top number. Okay.
Oh, okay.
And actually, in order to get into the kind of range of like a real diagnosis of pulmonary hypertension, the top number has to be actually over 40.
40, right.
Okay. But here's also the kicker. The Doppler estimates on an echo are not that accurate. Okay. We published a paper when I was still a fellow at Johns Hopkins. That was back in like 2000 and I think we published a paper in like 2005. What we showed was that when you did a heart cath on someone to like exactly measure the pressure, right? If you did an echo within 30 minutes of the cath, the echo would be off from the cath in about half of cases, okay? By more than 10 points. So let's say the cath said the pressure was 70 as the top number. In over half the cases, the echo would say the pressure was like 85 or it was like 55, okay? And it's actually one of the reasons why I dedicated a lot of my time and research into figuring out better ways to use the echo in pulmonary hypertension. And so just when they tell you that your pressure is 25, 35, 38, 28, whatever that is, understand that you have to take that with a grain of salt. And if there's any questions that like linger after that, you just tell them that you want to be seen by a specialist. I mean, a lot of what we do is seeing people just like you. Oh, I had an echo, my pressure was 41. What do I do? Right? And then we'll say, okay, and we look at the images and everything. We say, okay, this is either concerning or it's not concerning, right? So yeah, what you're describing is not worrisome at all.
All right.
Well, thank you everyone for being here. Dr. Forfia, thank you so much for your time and your talents. We greatly appreciate it. And I would like to say, I'm sorry if you friends look at the recording. I kind of missed pressing the recording button for the first little 5 minutes or so. So it's kind of started in the middle, but that's why. Thank you very much, Dr. Forfia. We really appreciate it.
Okay,
Thank you very much.
Thank you.
Thank you.
Appreciate it.
guys.
Thank you.
take care, okay?
Bye-bye.
Bye.